Hello. Hi, everyone. We're just going to start at 9:10, so if you want to grab some food and refreshments, you can do so now. Thanks.
Okay, good morning, everyone. We're going to get started now. For those of you who are not part of University of Toronto, one of the things I learned early on is that even though we say we start at 9, everyone starts at 10 after the hour. So we're now starting at 10 after the hour. Good morning. My name is Irina Creed, and I'm the Vice Principal of Research and Innovation at UT Scarborough. I'm just going to offer some opening comments. Some of you who are early risers will have seen the Globe and Mail article today. That's how connected we are. We can actually organize a whole spread on our conference topic in the Globe and Mail. In an aging world, seniors' loss of independence and quality of life is a preventable tragedy. This is based on a report coming out of the University of British Columbia, and basically this really aligns with the theme of today's event, that we want to improve the dependence and quality of life of our aging population. Some of you may be aware that this decade is one that the United Nations has marked as the decade of healthy aging. And the United Nations aims to improve the lives of older people, their families, and the communities in which they live. This decade has 4 action areas. The first is to change how we think, feel, and act towards aging. The second one is to ensure that communities foster the abilities of older people. The third one is to deliver person-centered integrated care and primary health services responsive to older people. And finally, to provide access to long-term care for older people who need it. Across the planet, the proportion of the population that is 60 years of age or over is increasing. 2019, we had 1 billion people over the age of 60. By 2050, we expect that to increase to 2 billion, which will represent over 20% of the total worldwide population. If you look at the map on the right, you'll see that there are concentrated areas where the aging population will be. One of them is Canada, also Europe, interestingly, Iran, as well as China. Why is the population getting older? It's partly because of declining birth rates, increasing life expectancy, and of course, the aging baby boomer population. You'll see that the greatest rate of birth rates occurred between 1940s and 1960s, which represented the baby boomers. Research has also contributed to longer life expectancies. This is just an example of the number of articles on human and aging that have been published since 1990, and you can see an almost exponential increase in these articles. If you look at the distribution of them, the number one area is in neurosciences, in terms of helping aging people address many issues related to the brain and a healthy brain. And people are also wanting to learn how to age better. If you just go on Google and type aging, you will see hundreds of popular books on aging. Some of them may be worth reading. And if you look at the one from Sanjay Gupta, who's the CNN chief medical correspondent, others maybe not so much. If you don't recognize the person on the right, that's Keith Richards of the Rolling Stones, who also has a book on aging. Now in Canada, the proportion of the population that is aging is particularly high. You'll see that we're having more and more people over the age of 75 as well as 85. And Canada's Institute for Health Research, what we call CIHR, has something called the Institute for Aging, and they've identified 3 strategic directions. Now these are based on 2019. I understand that they are currently working on a new strategic plan. But 2 key directions. One is in health and wellness over the trajectory of aging. They want to understand better one's life trajectory as a determinant of health and satisfying aging. And they also want to look at methods for adding life to later years. In terms of the second priority, it's about facing the complex challenges of an older population. And these include emerging new aging populations, understanding, preventing, and addressing multiple chronic conditions, ensuring adaptation of healthcare and services to an aging population, facing the challenge of dementia, and finally, informing late life care and decisions. The cross-cutting strategic directions include embracing an Indigenous perspective, building capacity and training, and looking at convener catalyst roles in addressing healthcare. At UT Scarborough, we have launched a network of research institutes under an umbrella called GTA RISE. The 3 institutes include one for Institute for Environment, Conservation, and Sustainability, one for the Institute for Inclusive Health and Wellbeing, And finally, Institute for Inclusive Economies and Sustainable Livelihoods. And I'm very pleased to, as of last week, introduce the new interim director of the Institute of Inclusive Health and Wellbeing, Professor Charles Trick from the Department of Health and Society. Now, the work of this institute will be closely aligned with the Scarborough Academy of Medicine and Integrated Health. And we're all still celebrating the news of this new Academy of Medicine that will be based at UT Scarborough. So today, our purpose is to promote system-wide actions to bridge the equity gap for our aging population. And it gives me great pleasure to now introduce Professor Mark Schmuckler, who is the acting chair of the Department of Health and Society. Mark?
Thank you, Irina. I want to welcome you all to this one-day conference on the Great Age, Sustainability in Aging Societies. I'm Mark Schmuckler. Let me give you a caveat. My training is as a developmental psychologist, but it is my privilege to be serving as the acting chair of the Department of Health and Society for the academic year 2022-2023. And it's truly an honor to be part of this welcome and the opening for today's conference. Today's conference is a follow-up to a recent conference, the Partnership for Inclusive Health, Bridging the Equity Gap in the Eastern GTA. This conference brought together UTSC health-based researchers, community health advocates, senior leaders, and its discussions explored health inequities within the Eastern GTA, with a goal towards better defining pathways to improving health and the well-being of communities in the region. The focus of many of these discussions was on the idea of health as a human right. This conference was incredibly successful in strengthening our current partnerships and opening new collaborative opportunities with a focus on identifying challenges that these communities are facing. UTSC wanted to pursue this dialogue with its strategic partners and beyond, focusing on specific thematic areas. And one such area that was identified was the issue of aging, which is the topic for today's conference. As Professor Creed has introduced, today's discussions are of critical importance for understanding the impact of aging on society. Preparing for the economic and social shifts associated with an aging population are essential to ensure the sustainability of society as a whole. This is critical for achieving a myriad number of goals, including reducing or eradicating poverty, ensuring healthy lives and well-being at all ages, promoting gender equality and full and productive employment and decent work for all. It's also critical to aspects such as reducing inequalities within and between countries, and ensuring other human settlements that are be inclusive, safe, and resilient. UTSC is actually quite proud to be part of the initiative to meet these challenges raised by the issues of aging populations. Foremost in our commitment is, of course, the Scarborough Academy of Medicine and Integrated Health, or the SAMIH initiative. SAMIH will be well positioned to address the undermet health needs of the Eastern GTA and the need to grow the cadre of health professionals to support an aging population. Proud to say, though, that SAMIH is just one of a set of current and future initiatives emanating from UTSC that are designed to address these challenges. For example, we are also developing a health innovation district, which is meant to support various initiatives at UTSC, combined with our local partners drawn from academia, healthcare, and in our communities. One of the goals of this initiative is to address the issue of health inequality in Scarborough and in the Eastern GTA. As another example, UTSC and the Scarborough Health Network have also organized a two-day conference in late November entitled Shaping the Future of Care, Eastern GTA Healthcare Conference. This conference will bring together leading minds to explore where we are taking healthcare, and its goal is to celebrate the emerging medical and healthcare education at UTSC and the partnership between SAMIH and the Scarborough Health Network. So all of this really just gives you a taste of the vibrancy and the excitement around the topic of health and society and the role that UTSC is planning on playing in these discussions and the responses to the challenges arising from this topic. Finally, just on a personal note, as a developmental psychologist who examines infants and children, I'm accustomed to thinking of aging as a process of the acquisition of skills and abilities and the integration of varying capabilities. Thus, it's both fascinating and eye-opening for me to think about this wholly different aspect and consequence of development, the implications of the aging process on people, institutions, and the society around us. This brings home a fundamental, at least for me, a fundamental yet often overlooked point, which is that development is truly a lifelong process, and that the impact of aging is seen throughout the lifespan. This is, for me, as I said, a welcome reminder, and I look forward to hearing and thinking about this throughout the day. So as I said initially, it is my privilege to be leading, even if only temporarily, one of the vanguards of UTSC's contribution in this regard, the Department of Health and Society. And it is on their behalf then that I welcome all of you to today's discussions. It is now my pleasure to introduce the moderator for our first panel, Dr. Samir Sinha. Dr. Sinha is also our keynote speaker for the day. He is the Director of Geriatrics at Mount Sinai, where my daughter was born. He is the expert lead of Ontario Senior Strategy. He teaches at IHPME at U of T, as well as at Johns Hopkins School of Medicine. He consults and advises on health authorities and procedures on how to implement and integrate models of geriatric care that reduce disease burden and improve access and capacity to promote health. So it is my pleasure to welcome Dr. Sinha to the stage. Thank you.
Thank you very much, Mark. It's a great honor to be here today, and a great honor to kick off our very first panel. I'm going to introduce my colleagues in a few moments who will be joining us for a good conversation. But what I wanted to do first was to really talk about, just give some introductory remarks. So the title of our panel conversation for this morning is our aging society unsustainable? You can ask it the other way, is it even sustainable? And so to discuss this, we've got some great people who will be joining me shortly. But I just wanted to give some introductory remarks that build on what we've heard so far. Because right now, when we think about our population, we saw some of the global numbers, we saw what's happening overall. But right now, as of 2021, 18% of Canadians are 65 and better, as I like to say. So we've got this population that, as of a few years ago, started outnumbering the number of younger Canadians, 15 and younger. So we know that we're an aging population, but as the key goal of this conference is that we know that within 10 years' time, in less than a decade, 1 in 4 Canadians is going to be an older Canadian. So the question then becomes are we ready for this big demographic shift that's even about to come to bear? Whenever you look at our headlines in our Toronto Star, for example, we heard about a great headline today in the Globe and Mail, but this is one that we usually see from our local paper, asking questions like, are Ontario's hospitals unprepared for an aging population? You might think this was written the other day, for example. This was actually written about 5 years ago as well. So this is not a new conversation. This is a conversation we keep having, but it seems like the issue becomes more and more acute as every year passes us by. When we think about questions about are we prepared for the needs of an aging population, as of 2019, we had 430,000 Canadians reporting that they had unmet home care needs, and over 40,000 people were on nursing home wait lists. I can tell you that due to the pandemic, we have that Canadians and over 52,000 Canadians waiting for nursing home beds. And you can imagine that if we're not providing enough home care, well, where do people go? Well, they end up in nursing homes, which is not necessarily where they want to necessarily be. So this is why we start talking about, well, are our hospitals ready for an aging population? Is our home care system, is our long-term care system ready? And of course, any of us who've been paying attention to what's happened during the pandemic knows that the answer is probably not at this moment. So of course, the question becomes is aging a triumph or a tsunami? People often use this word tsunami all the time. People don't really focus on kind of the positive aspects of aging and thinking about what this can do. So to kick off our panel, what I wanted to do is first of all ask this question to all of you and ask the question, is aging a triumph for tsunami? So Brice here is going to help me just ask this question to the audience.
Hi everyone, so during the day we will have some interactive questions, or we will ask people, during the day we'll have different interactive questions, or we invite you to provide information or your point of view or opinion about aging. So this is the question. So in order to be able to answer this question during the day, you will have two options. Either you go with your phone or your tablet or your laptop to the site menti.com and you enter the following code, 711404888. Or on the table you have also this information. And if you want, you can also just scan the QR code that is on the paper or on the screen, and you should be able to also to access the presentation. So I'll just give you some time.
Perfect. And so while everybody is putting their code in, I'm going to use this opportunity to introduce the panelists who will be joining me today. So as I announce your name, if you can please come up. The first person I'd like to introduce is my colleague, Dr. Amer Burhan. Amer is a diplomat in neuropsychiatry and behavioral neurology. He's also a geriatric psychiatrist, and he's the physician-in-chief and research chair in applied mental health research at Ontario Shores Centre for Mental Health Sciences. He's also an associate professor in the Department of Psychiatry at the University of Toronto. Dr. Jennifer Campbell is a senior scientist and associate director academic at KITE Research Institute at the Toronto Rehabilitation Institute, affiliated to the University Health Network. She's also an associate professor in the Department of Psychology at the University of Toronto, and she's the associate scientific director of the Age Well Network. Dr. Andrea Carice is an associate professor and the associate chair of research at the Department of Health and Society here at the University of Toronto's Scarborough campus. She's also the director and principal investigator of Flourish, a research cluster on community-engaged arts for social wellness. And finally, last but not least, I want to welcome John Stapleton. John is a writer and instructor and former innovation fellow with the Metcalf Foundation. He's also a member of the expert panel on income security at the Council of Aging based in Ottawa. He's also a senior researcher at the Neighborhood Change Research Partnership, a research initiative of the University of Toronto. And as we did that, we have our answers. And right now, we have 62% of our participants saying that aging to them is a tsunami, and about 38% saying it's a triumph. So with that, I'm going to start off our panel discussion, and thank you very much, Brice. So I wanted each of you, if you could please just introduce yourselves a bit, in terms of why are you interested in this topic, and then give some thoughts. You've heard what the audience says. The majority here think that aging is a tsunami. So Amr, can we start with you?
Yeah, thank you so much, first for organizing this amazing opportunity, and also for bringing us all together. I'm privileged to be among this fantastic panel. As you heard from Dr. Sarah, that I'm actually a geriatric psychiatrist, and my work is in mental health field. So when I look at these questions and numbers, I always wonder, could we change it from tsunami to a triumph by changing the way we do things? And I think, from my perspective, one of the, of course, from where I sit as well, that mental health is one area that could make it a tsunami versus triumph. So people who are aging with challenges in their mental health. Depression is an example that kind of is a big piece of what we deal with in geriatric mental health, and also behavioral aspects of dementia. I think most of the time that's what creates the tsunami that results in the need for a person to leave home and be in a care facility, only to find out that the care facilities are not prepared to address their needs. And that's why, for me, there's a lot of opportunities, I think, and in the integration of the network of care may create the opportunity for us to shift it from tsunami to triumph. An example, of course, that depression affect outcome from almost any medical illness that you can think of in old age. After a stroke, a depression increase mortality, increase disability. The same with so. There are opportunities, and I think as I hear from my colleagues here, we're probably going to find out that each one of us have some ideas how to make this shift from tsunami to a triumph.
Jennifer, what are your thoughts?
So yes, echoing Amber, I'm also very pleased to be here and thank you for organizing a really important conference today. I actually don't think that tsunami or triumph is exclusive. I think they can both be true in many ways. I think we're very aware that we've had a lot of triumphs in our aging society. People are living longer. They're living more healthy lives than any other time in history. If you survey people, it is actually this life stage, older age, for which people express that they are actually the happiest. They are big contributors to society, extremely productive and socially committed in many cases. So there's a lot of triumphs that are happening in terms of aging. My own research is in the context of aging well. So despite the fact that we are very aware that many declines in physical, sensory, and cognitive health happen as a function of biological aging, people can still live very well and live healthy, participatory, satisfying lives, even in the face of those declines. So I think that what we have to do is to put our efforts into understanding how to allow people to live their best lives in the contexts in which they live and the challenges in which they face. One of the ways is obviously in the context of prevention, which is what my own research is in. How do we prevent injuries or illness from happening in the first place, such as falls prevention? How do we support aging well through, for example, supporting sensory health? I do a lot of work in vision and aging, or vision and hearing, sorry. But in one of my capacities, was mentioned in the introduction, is that I'm associate director, scientific director of AgeWell. And AgeWell is a network that focuses on technology development to support the aging population. And so if I were to apply a technology lens to this question, I would say that technology can have a large part to play in facilitating the process of aging well. So we saw this very clearly during the COVID pandemic, that technology was a huge asset in terms of keeping us connected, for example. Age-related tech can be as simple as apps that facilitate medication reminders, telehealth, telerehab to support physical and cognitive health programs, all the way up to social robots and automated vehicles. And so I think that there's a lot to be said about how technology can be applied, but of course not in isolation. So some of the big challenges are, how does technology intersect with services, with the healthcare system, with policy? And I think that's one of the big challenges. The other challenge in terms of sustainability is always, as was already touched on in the opening remarks, is equality or equitable access to services, equitable access to technology. And so I think that if we can successfully bring these things together, then we will move more away from the tsunami and more in the direction of triumph. Pass it on to.
Well said. Okay. Andrea.
Hi, everyone. Really a pleasure to be here and an honor to be speaking alongside these wonderful colleagues. So just a bit about my background. I guess each of us is unique in our own way, but one of the assets, perhaps, or insights that I bring to the table when it comes to aging is a background in literary studies and an attention to the ways that the literary arts, our language, and the arts more generally inform and possibly expand how it is we're able to think about aging, what aging, how it is framed as a concept, you might say. So for me, thinking about the language of the tsunami is a trigger issue for me, to be honest. In my view, aging is anything but a tsunami, if only because if we look at that word, what it actually means, sort of from the dictionary. I hate to be that person at the cocktail party, but the dictionary definition of a tsunami is a sudden surge of water, often unforeseen, with massive social destruction to infrastructure and so on. And that is absolutely not what an aging population has been. We've known of this demographic shift coming for decades now, and we don't foresee tsunamis decades in advance. So what we're really seeing now, in my view, is not a tsunami of people, but in fact the outcome of decades of a lack of will to prepare for this very moment. And this language of a tsunami, just more generally, has long been deployed to talk about groups of people, of them, that is not us, that we don't like the idea of very much. And another comparable I'd raise in this context would be at the beginning of the 20th century, American immigration, when there were lots of folks coming over from China and Asia more generally to North America. This was a phenomenon referred to in the popular media as the yellow peril. And I see a direct, just even in the way that the gray tsunami as a phrase is constructed, a direct parallel between the ways that certain populations or influxes of people that are understood to be not us for some reason are demonized or are framed in a way that is meant to generate fear, distrust, some kind of, there's something wrong with those people that are described in these ways, right? So this is actually, if we look to the history of language, we have a long history of talking about groups of people that are again, have a kind of an outsider status that I think is important to kind of put in the conversation of how we're talking about older people today. But I don't think, by the same token, I don't think that triumph is quite the right word either. As always, it's a triumph for whom? I think in some respects, obviously, it's a public health triumph in terms of expanding longevity experts, older age and longer life expectancies may indeed be a triumph. But I don't think it's a triumph. I don't think the condition of older age is a triumph for the personal support workers that do not have a living wage, that are not supported in their work for older people. I do not think aging is a triumph for low-income seniors that are very, very precariously housed or unhoused in their older age and are subject to not just systemic issues, but the language of ageism and the effects, the lived effects of ageism as well. So I could obviously go on. We have an opportunity to do that in our discussion. But I'd like to offer a third term, which was not on the list for us. And again, this is coming out of my interest in language and storytelling. And that third T term is transformation. And that's an option in every story, every narrative that's told. And a transformation doesn't necessarily mean it is good, it is bad, but the inevitability of change is, and the risks that are part and parcel of change are very much, I think, something we can look at more clearly with respect to an aging population, and to try to draw out the possibilities, how that transformation offers us opportunities, but also the risks or the considerations, the ways of thinking of our society and individual lives anew. That, for me, is where I like to navigate between the idea of a triumph and a tsunami. Thanks.
Well said. John, to you.
Thanks, Mayor. And again, thank you for putting this on. Thank you for this important opportunity this morning and this afternoon. It really is quite important. So my name is John Stapleton. I have a tiny social policy consultancy called Open Policy. It's here in Scarborough. It's in Milliken. And my background is as a benefit designer. There's not that many benefit designers in Canada. I think there's a few hundred of us, and we all tend to know each other. And I've worked on the design of the National Child Benefit. I'm working currently on the design of the Canada Disability Benefit. So if anybody wants to bend my ear about that, I'll certainly be, and looking at adjudication as in regard to the current federal disability benefits, and also working with the Denmark Institute on ending working poverty in a number of cities, small cities in Canada, and also working with the Ontario Native Welfare Administrators, along with the Assembly of First Nations, on changing social assistance, or what's sometimes called income assistance in Canada. So I think the reason I'm here is because I do a popular seminar, I hope, on low-income retirement planning in the public libraries in Ontario, in Hamilton, and Ottawa. And you're about to hear a bit more on that this afternoon in the session that I have with Dr. Block. But certainly, trying for tsunami on the side, I'm obviously, I think, as a card-carrying senior, I'm on the side of the triumph. I like to think that that's what we're all about, right? We all want to live longer, and we live in a society that has managed to do it, and somehow has become wary of it once it happened. Now, why would something like that happen? And it seems that some of the thinking, I think, that has gone into that is the worry about, again, as previously noted, that there's a sudden upsurge that, well, not really. The median age of Canadians right now is 41. So it means, median means that there's half the population is sort of 41ish and below, and half the population is 41ish or higher than that. In 1955, the median age of Canadians was 27. We were a very young nation in that sense. And so we have seen ourselves, and I think we feel it as a nation, when we have something like a baby boom, followed by a Great Depression, and the birth rate went down terribly in the Great Depression, and then it went down even more during the Second World War. And so there was a lot of catching up to do, which caused the baby boom. So in many ways, it's quite an abnormal couple of events there that went from 1929 through to 1946. And so we start to see this median changing from 27 in 1955 to 41 today. And where's it going to go to? Well, by 2035, that median is, by demographers, good evidence for this, that the median will go to age 44. Okay, so we got 3 years. It's kind of slowing down a bit. But then it really slows down. And by 2050, we're only expecting the median age to go from 44 to 45. And why is that? Well, you think of the cartoon character where you see a snake swallow a watermelon whole, and then the watermelon goes through the snake. Well, that's kind of what the baby boom is doing. And so when the baby boom that started to turn 65 in 1946 and then started getting old age pension in 2011, wow, you should have seen the amounts of money going out for old age pension just shoot up in that year. And of course, it's an index pension. And so our oldest baby boomers right now are 76, and our youngest baby boomers are 61. So they are traveling through this advanced age thing. So it can feel like a tsunami in terms of that baby boom generation. But at the same time, what's really the biggest problem here, as I see it, and I know we're going to get into this in a second, but just to mention that we have a field of demography, conservative demographics, that tend to look at the people turning 65 as, and I'll say the word, and it's an awful word, but dependent. They are somehow dependent on the people who are 18 to 65. And so it looks like a tsunami when you start to think of those people who are turning, who are aging into the baby boomer, into that 65, and there's piles of them that were born in 1961 that are, there's piles of them turning 65 of that group between 46 and 1961. And but does it make them dependent simply because there's a field of demography that starts out with the idea that if you're 65 or over, you are, but it's axiomatic, using deductive logic to say you are suddenly dependent when you reach that age. And so that's part of the framing that we need to talk about, the framing of people who pass an age line of 65 suddenly changing their status. And there's all sorts of reasons why that's not true, but I think I'll stop here.
Brilliant. So we've heard some for triumph, some for tsunami. We've heard about the word transformative, right? I'm going to throw in a fourth word just to add in some controversy, and that is glacier. Someone was saying, why do we think about this as tsunami, as Andrea said, whereas when someone said, when you've known about this demographic transition, as John just kind of labeled it really nicely, from 1945 onwards and so on, someone said, this is not a tsunami, this is a glacier. In fact, we've been seeing this coming. It's now coming. It'll slowly march along. John has just shown us that we don't really have apocalyptic demography here, that actually our median age is slowly creeping up, for example. Yet, I think as Andrea said, and our colleagues said, that sometimes it does feel like a tsunami when really it could be thought about as a glacier, that we know what's happening. So how do we actually think about this? And I think this is where Amer and Jennifer were able to talk about the positive ways and the things that we can actually do from a mental health perspective, but also an aging well perspective. So I want to get to our next interactive question, and then I'm going to throw our next question to the panel. So I'm going to have Brice help us out here. And the question basically for everyone to participate in, is it correct to think of older people as contributors or as a drain on our societal resources? So are they net takers or net contributors? I think John introduced that concept a little bit about this idea of the dependency ratio. But again, do we see older people as contributors or as a drain on our societal resources? So we'll give folks about a minute and then we'll go from there. Okay, I hope we haven't influenced the conversation. I'm actually very surprised by this response here, because I would think that societally, we always hear about this term, the dependency ratio, and John raised that term, which I always bristle about whenever I hear. But I'm going to go in reverse order now, or actually no, I'm going to go back around the original direction here, and I'd love to hear, Amer, your thoughts. Net takers or net contributors, and why?
Right. So I mean, this might be a reflection of people who care about aging, attending this conference. So they're on our side, I guess, to want to believe and truly believe that older adults are contributors, and then definitely we have a lot of successful, successful colleagues and contributors to the society who are above 65, but that's the cutoff. I think we all agree that the cutoff may have to continue to change to older cutoff. I mean, for me, again, this is kind of back to the question about tsunami. I think it feels a tsunami when you're not prepared for something that's coming your way. I think John was mentioning that, all of a sudden baby boomers are going to be collecting pension, and all of a sudden there is a tsunami for that particular year when people say, well, at this time I'll have to pay more for those people. And the fact that median age will be in the 40s, mid-40s maybe, for me it's significant in the sense that that's the opportunity to prevent negative outcomes from aging. I mean, again, we're an amazing panel of different contributions from sociology to policy making, and from the clinical side of things, I mean, I see that as a way to kind of create that opportunity to prevent negative outcomes in aging. And I think, from mental health side of things, an example would be like a depression in middle age is a predictor of Alzheimer's disease, right? Or dementia in general. And, we still have not done enough to say, could we change that trajectory, right? You can only imagine how disabling it is. In fact, depression has been for a long time number 2 disabling illness worldwide after heart disease, and it's actually surpassing heart disease now. So think about, if you're a middle-aged, not even old, and you have depression, you're not going to be a contributor. You're going to be somebody who is, thinking that that's it. That's the end of my contribution to society. And those are modifiable factors. So, providing access and also reducing the stigma around pursuing mental health care, for me, there's one way to actually change that sense of apathy that people feel when they're depressed. So again, it is a tsunami for me in that sense when I see mental health not being treated in that age group. It is also problematic for me when I see people who started developing cognitive changes and then their level of support is so not adequate at home, where they think that that's it. I can't drive. I can't do this. Driving is a perfect example. You navigate your community through driving. You develop a cognitive change. All of a sudden, you know that people are gonna look at you as like, well, you shouldn't be driving. Well, it's not true. Like, you don't need to stop driving if you have more cognitive change. So, looking at it from that angle, I think we can switch a lot of the, dependents into contributors, because we take away the barriers. And probably going to be true for Jennifer's comments around sensory. I don't want to speak for you, Jennifer, but for me, the barriers against contribution is what I think. And old age is not just one thing. 65 now becoming very, less likely to be the cutoff that we're going to use down the road. So,
Jen?
Yeah, absolutely. So I was excited to see this statistic pop up from our audience, because I am in agreement with the majority. I think that older adults are certainly contributors. So they're contributors from the perspective, as I mentioned earlier, in terms of volunteerism. It's one of the largest demographics that are providing their time, unpaid time. They are retiring later. We're seeing a shift from people actually retiring completely from one career and having that be it, to actually shifting careers. So seeing retirement as an opportunity to change careers and contribute to the workforce in different ways. But I echo the earlier comments about the extent to which we can support their ability to be contributors. Means that we have to make opportunities accessible, and we have to remove barriers. And so from the perspectives of keeping people within the workforce and keeping them active and productive in the workforce, to make sure that the working conditions are actually amenable to ensuring that people are productive and satisfactory and reaping the benefits of continuing to work. And we see this statistic even now, and I know that part of this is certainly due to COVID, but people are being called back from retirement. So we've seen in a lot of fields, people being asked to come back to work because we need that injection into the workforce, because we have some gaps. And so I think everything that we can do to kind of open up those pipelines is going to be, really important. But the other thing that I wanted to mention is that we unfortunately often use the word older adults to refer to a very large part of our society in terms of demographics. And I think we can all agree, although this is certainly a generalization, that an average 65-year-old can be very different than an average 95-year-old. And someone who's living at home independently or living at home with care partners are the majority right now. So we do have many individuals who are in long-term care and who do require different types of resources. But I don't think we should paint all older adults with the same brush when we're trying to answer this question as well. So the extent to which somebody can contribute, to the extent to which someone does require additional resources, is going to depend on all kinds of different circumstances. It makes it difficult to answer this question as a function of age. It would be easier to answer this question as a function of individual situations and conditions and what they have access to.
With Andrea.
Yeah, I think my comments will follow yours nicely, Jennifer. Yeah, the idea of older people as a drain. I mean, based on what I said, I think in the first round, we don't need a Mentimeter for you to probably guess like where I'm going to land, like on the meaning of that word, right? I mean, in my view, thinking about people, whether it's older people, any group of people, as a drain on human resources is so profoundly dehumanizing, so profoundly against the tenets of a social welfare state that I'm always kind of on high alert when I hear that word being used, because it suggests to me that there may be reasons why, or an agenda around putting wedges between people who contribute to society at any stage of their lives and what I think, at least in the Canadian context, we ought to expect from a state that is guaranteeing us certain levels of social welfare and decency of life. So that's certainly my starting point with respect to that word. We all drain. I mean, if there are any parents, babies drain. Teenagers drain. I mean, this is not I would, again, this is where I think I echo you a little, maybe a little foolishly, but we're humans. We are drainers of those around us and the world in which we live. So to mark that specifically as an age-specific habit is something I am very allergic to, you might say. It also, it only really makes sense if we have all agreed, we consent to the idea that a economic framework is the only way we are going to understand and look at aging, and more specifically an economic framework in which gain is all, and that is common to capitalism especially, right? So if we have a gain-drain dynamic, which we've decided to sort of think through age, we are really limiting our imagination. We are really limiting the possibilities that older age might present us. And one of the things that I was imagining my answer to this question earlier today and last night, I thought, well, what is a drain? And are there ways that drains don't mean what they do in this respect? And your suggestion of a glacier, Samir, made me think, well, from an ecosystems perspective, from an ecological view, we need drains, we need basins, we need reservoirs. Those are part of a cycle of, whether it's the traveling of water or other resources, where that stasis or that collection is actually an essential element of a healthy ecosystem. And so maybe that's an example of where an ecological framework for thinking about aging versus, or in contrast to an economic framework of thinking about aging, maybe asks us to think a little more creatively about what a drain might involve. Is a drain bad? Is it a sucking away towards nothing, of net zero? Or is a drain, in an ecological sense, serving as a reservoir? Is it an opportunity to bring back or cycle through yet again qualities that may be very specific to an older yet heterogeneous population? So I'd encourage us to sort of think about how a word like drain powerfully is motivated by an economic framework, and that's not the only way we need to be thinking about aging. And I'll proffer the ecological view as one way that we might kind of think ourselves out of drain as a kind of pejorative term, something that takes away individuality, takes away agency, instead of giving it back. And that's what I think reframing it, say, in ecological terms, might allow us to do.
Perfect. John, your thoughts?
I'm going to give you my observations from a benefit designer perspective. And currently the orthodoxy, when we think of, again, back to the demographics of dependency, the orthodoxy is that seniors, people over 65, work less. The second is that they spend less. And the third is that they pay fewer or lower taxes. this is part of the assumptions of the orthodoxy about what happens in terms of people when they turn this magic 65, they retire, and when they retire, they don't work less. Secondly, they spend less because they don't have as much money. And thirdly, they're not taxed as much because if they're not making that money, then in fact they will be taxed less. Can we please look at some evidence rather than simply asserting that orthodoxy? First of all, in 2006 in Ontario, we ended mandatory retirement. What did most policy people think? And I know because I talked to a lot of these people at the time, was it wasn't going to make that much of a difference. Guess what actually happened? Every element, every demographic within the seniors population, junior seniors, middle seniors, senior seniors, women, men, all started to work more. So as the decline, like the early retirements, remember Freedom 55? Seems sort of antiquated right now. The idea that retirement is freedom, whereas now people tend to think of as retirement as something that you can't do anymore because you're going to need the money. Well, people started working, and the number of people in Canada and in Ontario that began working past 65, starting in 2006, completely made up for the loss of people who were retiring either early or later on. Completely made up that loss, plus women coming into the labor market, which was continuing to happen, and especially in senior positions. And also that where we saw some of the greatest labor losses was actually amongst younger people who were staying in school longer. So if you're going to do this type of counting, you can't just juxtapose the senior population over 65 against the 18 to 65 population and make assumptions about working less, because actually enough work more to more than offset the issue. So now, do they spend less? No. Poor seniors who are on programs like Ontario Works or ODSP, all of a sudden get this huge boost in income that takes them from, well, ODSP now is about $1,200, and boom, all of a sudden they're making $1,709 per month, which is what old age security and GIS for a 65-year-old is right now. So they're making more. They're getting money, and believe me, they're spending it. And so we're seeing the poor seniors. The other seniors, our whole system is set up for people to spend. And what the actual, when we look at GST, we see a lot of savings amongst people who are lower than 65. They're not spending as much because because of the responsibilities they have. But seniors are dis-saving, and so they're spending more. And because they're spending more money, especially in the early years at first, they're paying more money out in GST and HST than their non-senior counterparts. And they are also spending more when they hit that point where they would go into care, something like long-term care, or into a senior's home. I can tell you that there is the explosion of money being spent by those seniors. And where's it coming from? Well, we have to remember that if you bought a house in Toronto in 1870 and sold it in 1932, you actually lost money. But if you bought a house in the 60s or 70s and you're selling it today, you have a 10-bagger at least. And once that sale takes place, that money starts to come out, and it's getting spent on adult children, it's being spent on cars, but it's mostly being spent on care. And I take the example of my own parents who recently deceased, but they both reached age 99. It was in their 90s when the spending spree really started to happen. It was all on care and aspects of care and money going into to adult children, a little bit to me. The third is they pay less taxes. No, they're not paying less tax. Look at our system. Look at our taxation system. What happens when you turn 65? OAS is taxable. CPP is taxable. RIF money that comes out at 71 is taxable. Take anything out of an RRSP, it's taxable. All pension forms are taxable. Seniors have more taxable forms of income in the income. So not only are they spending more on HST and GST, they're actually spending more, they're actually giving more money in income tax being taken off them. And then they hit 71, what happens? The RRSP chariot turns into the RIF pumpkin. And all of a sudden the money is forced out of the RRSP accounts to the point where it starts off at 5%, but once you reach 95, if you're lucky enough to do that, the RIFs are coming out at 20%, all taxable. And a lot of that money is taking people, starting to take 3% of our old age population right out of their old age security payments. So we're seeing percentage payments in terms of marginal effective tax rates in the area of 60 to 70%, which is far higher than the highest tax rate for somebody under 65. So they're paying more in tax. So what we have to do is go from deductive thinking in terms of making assumptions and start doing some inductive thinking and saying, can we look at the evidence? And when we look at the evidence, all those issues of dependency simply disappear in the present context.
It's brilliant. So we had some really neat insights with this next question, right? Again, John has just helped us kind of do the math and realize that the math shows that older people are more net contributors. It's really neat to kind of, again, hear these different kind of, again, angles about how we take a look at these issues and how we think about, you know, as Amar was saying, you know, we have too many barriers to allowing people to be contributors. I really liked what Jennifer also had to say about, again, what are these things that how are we, you know, again, categorizing the society when we think about the roles they play. And one thing that triggered for me was noting how when we actually delved into what were some of the things, what was one of the biggest issues behind the labor shortages in our pandemic, you know, we had all these theories that were coming up. And what we realized, it was, you know, this idea of the Great Resignation. And it wasn't just that people were just saying, I don't want to work anymore. It was actually retirees. It was actually people taking early retirement, whereas Jean was saying older people like to work, but there were a lot of people who actually had the ability to say, I don't need to do this anymore. So again, it's what is that role and how well older people, when they don't contribute, when we don't allow them or encourage them to contribute, it can really be a net loss for a society. And one of the thoughts I had was about this reservoir, this concept of thinking about older people as a resource that Andrea brought up was, remember a quote that I heard that really moved me during some of the dark days of the pandemic. There was a First Nations community in the Yukon, and there were, I think, 1 or 2 cases of COVID that came into this very remote community. And so the chief asked the entire community to self-isolate. And so this chief was being interviewed and said, why have you made this decision to tell your entire community, young and old, to self-isolate when you only have 2 cases in your community? He said, if we lose an elder, we lose a library of knowledge. And I just was so moved by that statement about saying how our greatest resource in this community are our elders, and they each are a reservoir of knowledge in that way. So again, some really interesting thoughts to take us to our third question for the panel, which is, and then I want everybody here to prepare their questions, because we're going to have some time for you in a few minutes. But the third question I want to ask, but just to the panel, was what should we be doing better to ensure that aging of our society is both sustainable and successful? So I think we've heard some of the hints that have been raised, but But I'm going to start again with you, Amar, and we'll go around. What should we be doing to ensure our society is both sustainable and successful?
Yeah, I think one of the amazing things is as you hear different perspectives, particularly thinking about the society, finances, and the data, that it kind of brings some of the issues that I did not consider when I deal with people who have illnesses that disable them. So we think about illnesses like depression or the dementia kind of disables people, or the combination of a depression and a stroke. But then I also have seen people who retired because they had no choice. They were let go because of a disability. And I can tell you, I work with senior veterans, and some of them would have left their service, worked, and then at one point, some of their injuries from their service stopped them from working in that particular job that they love. And it's almost, at least I'm biased because all that I see is that the reactivation of post-traumatic stress disorder, depression coming at the time. And they say, well, I should be like having more time to enjoy myself, but now I don't seem to be able. I'm sitting home doing nothing when I now could do it. So it came to me while you're discussing the reservoir, you're discussing the financial reality, that we don't have that integrated approach to this, where you say, well, could we actually say your first career gets you to retirement. The second career is actually leveraging your wisdom to actually serve you as a person to continue to have meaning, because meaning is really what keeps us going. I have a colleague who's a geriatric psychiatrist, and he was declaring his retirement, from 65 and delays it to 70, then to 75. And his fear was, I don't know what to, I'm going to be depressed not to have a meaning in life. So I really feel that, a panel like this kind of opened my eye to the fact that if we talk to each other and say, what if I ask you for advice, John, about, this senior who has been asking this question, clinically, I can't answer that question. I can help them with their depression, but I can't really address the rest of their life. What's the meaning of your life after retirement? We do have forms of psychotherapy that talks about transitioning to retirement and the meaning of life. But I don't think we've ever used the data that you mentioned to actually give those solutions, right? So the lack of integration in our thinking, I think it should be something that we prepare people for, create an opportunity for people to actually have maybe even a workshop to say, now that you're approaching the end of this career, let me tell you about what other careers you can do, not to stress yourself out but also the financial implication of this. Some people tell me, well, I couldn't really take the job because I'm going to lose this. So I'm not informed about that. I don't know how to advise them in these areas, right? So to come back to your question, it's really about, first revisiting this whole thing and come up with an integrated answer, not just, I can give answer from my end, but I don't think I'm doing it justice, because there's society out there, there's caregivers and adult children of people who's asking this question. So are you telling me that if my dad has to go to work, I have to drive them there because you told me they can't drive anymore? There's a lot of logistics that we have to think about. So for me, this is a good opportunity to start that conversation. I think we should have really a good integrated answer for this. And it's going to be a set of, hopefully, workshops and discussions between people with these kind of backgrounds to come up with a solution. Clinically, I can tell you what I can do for the person, but I don't know what to do for the person in the society, right? And how to leverage their expertise and enable them through maybe selecting what tasks they can continue to do, and not feel that they have to push themselves and stress themselves out. Yeah.
Jennifer.
Okay, so I think I would be remiss if I weren't to say part of the solution could be and should be technology-based solutions. And so, not that technology is going to be an all-inclusive solution, but I think it has a lot of potential to allow people to maintain their capacity to stay connected, socialize, to maintain their independence. We hear from a lot of people that they would like to age in place. And what they mean by that is to say they'd like to age in their homes, in their communities that they're familiar with for as long as possible. And a lot of the age tech can facilitate that, in addition to, sort of, like, I think computer-based, consumer-based age tech, as well as medical devices. But I think there's a lot of consumer-grade age tech that's going to be making big waves and having big impact. But of course, technology can be inaccessible. It can be expensive. And so we need to be cognizant of that to make sure that we're concerned about things like cost, accessibility, usability, and privacy. And also aesthetic. We don't think about this a lot, but going back to this issue with stigma and stereotyping, there is a lot of ageism, and it does apply to the development and design of technology. So one of the most common ones I like to reference is that hearing aids are stigmatized. A lot of times people don't get their hearing loss treated because they don't want to wear hearing aids, but ear pods are totally acceptable. And so now we're starting to see shifts, right, to create technologies that are more accessible, less stigmatized, and in fact start blurring the lines between age tech and everyone tech, universal design and accessibility. So I think technology is going to be part of the answer. In addition to that, personalized healthcare is going to be very important, I do think. That's going to require interprofessional engagement. So oftentimes in the healthcare system, things are working in siloed ways. I see this in my own work when we look at older adults' cognitive health being evaluated separately from their sensory health, separately from their physical health in many cases. And those things are all intertwined and are connected to each other. We know, for example, that hearing loss is actually the #1 potentially modifiable risk factor for dementia. And so if audiologists are aware of this fact, then we can work towards mitigating some of these potential cognitive declines that come with hearing loss. And so I think opening the communication across healthcare professionals, across policy, people who are determining policy and contributing to policy development, as well as tech, there's professional intersectoral collaboration to be able to answer this question. Two more quick things. One is that I do think that there's a role for intergenerational connection and access. And so engaging kids and youth into these conversations is going to be really critical. This is perhaps ambitious, but we do need a complete cultural shift and overhaul in terms of how we perceive aging. And I think the way to start is to start with kids, to give them access to many positive views of aging. We know that positive views of aging in and of themselves can actually also reduce biological aging. So if you feel good and positive about the aging process and you hold it in high regard, like we see in many cultures, including Indigenous culture and other cultures around the world, that's going to have large societal impact, but that's also going to have personal benefit. And so intergenerational programming and communications, I think, is going to be key. And the last thing I'm going to say is that above all else, when we're making these decisions and creating impact and developing technologies, policies, whatever it may be, we need to have older adults at the table. We cannot be deciding these things for older adults, but it must be with older adults, and it can't be tokenistic. It has to be integrative and instructive. So that I pass it to Andrea.
So, Samira, I had a quick advocacy for hearing aids. I'm wearing my hearing aids, and I dealt with that issue as well, the stigma of it. And then I thought, well, it's going to prevent 9% of the dementias, then I'm going to wear it. I mean, and to tell people that you could have hearing loss in your 40s and 50s if you have the genetics for it, and why don't you want to prevent dementia? So just putting a destigmatizing statement that I'm happy to say I have my hearing aids on.
Andrea.
I think absolutely in agreement with you both. I think for me, the question, that is motivating today's conference, sustainability in aging societies. One of the elements for me, and I'll repeat a point that you've made, Jennifer, is aging is a life course issue, right? Aging is not a problem for or about old people. Aging is the one thing we are all doing. Our experience of aging is, of course, individual, distinct, demarcated not just by individual qualities, but of course the communities and the settings, the context, the locations in which we are all raised. Of course, those things are specific, but there is something compelling in the fact that aging is as close to a universalizing experience as all of us here in this room are going to have. which is, again, just to emphasize, not to say that it's all going to be the same, but there's something that we are all undergoing at the same time together that, for me, makes aging not just a life course issue, but something we are truly doing from birth. And so your point about, having the opportunity to think about aging, to integrate how it is we want to live our own old age in childhood, in schools, in K-12 education, that for me is a practical, but I think also socially and culturally actionable move that we can make that is going to allow aging to be something we can address outside of the clinic, outside of the hospital, outside of economic conversations, right? That's a way that aging can be addressed and encouraged and cared for, within our communities, way before we ever have need to step in a clinic. For when the time is right to step in a clinic, that's the time to do it. But there are so many opportunities to think about and cultivate aging outside of that when we are in community. And I would say to that extent, and related to these points that Amar and Jennifer are bringing up, is that I see a much bigger role for the arts and culture sector in helping do this work. And you were talking about an integrated approach. And again, this is, with all respect, all love, respect for my clinical colleagues, I think one of the ways that we can think about integration is before we walk in your office door, what are the resources that are already existent in community that can help facilitate these practices of wellness, these practices of engagement, these engagement in arts or arts-like activities that might help with hearing loss or just help with encouraging senses of belonging, these things that are not clinically relevant outcomes per se, but have clinical impacts in the longer term course of one's wellness. So that's where, for me, I see a really important aspect of our integration is looking to the arts and culture sector and seeing that as a friend, a colleague, a codependent strategy for the kind of clinical outcomes that we're all interested in. And just recognizing in one way or another, aging is not a single sector problem, right? We need multi-sector solutions. And by not turning to the arts and culture, which is an enormous reservoir of really community-based, ground-up knowledge, that is a huge oversight and something that we're not tapping. And I think that's part of our all hands on deck policy from now on. It ought to be anyway.
John?
For me, the biggest problem, and I think the solution here, is to take negative aging stereotypes and turn them into positive aging stereotypes. We know from some of the American research that has been done that seniors who have positive aging attitude live up to 7 years longer than people who have a negative frame. And we know that in terms of cardiovascular events, we know that people who are under the age of 60 who have a negative disposition towards aging are likely to have a cardiovascular event more. They will have it more than the people with the positive aging stereotype. So where do I go in terms? I'll give you two personal experiences. My mother started a Meals on Wheels route in 1986 with a United Church. It got taken over by Wood Green in 2002. And together, for most of those years, we did it together, but we did that Meals on Wheels route for 32 years. And we got to see people who were, I guess, aging in place in their own homes because we were bringing the meals into them. But the rate of hospitalization amongst people who are seniors living in their own home who had this disposition towards inactivity. I still remember people who sat in the same place, on the same couch, watching reruns of Murdoch at 11 o'clock in the morning and did that just continually, and then just having a mental sense of the passage of people going on. It was the really, really inactive people, the people who had their own disposition towards life as being inactive and not doing anything. They didn't need to get out. They shouldn't get out because, well, they're seniors. They don't have to do anything. They're retired. They've retired not just from work, they've retired from life in many cases. And so we got to see this. Now, my own mother quit the Meals on Wheels route. Once she discovered that she was older than everybody on the whole route, she was still doing it at age 89. So, but that activity, it really had a lot to do with the fact that she got to 99. And I just see that in terms of the activity and having more and more medical problems. So I think if we can turn it on its head for both the seniors and the near seniors and even younger people to think about a positive, active lifestyle that includes exercise, concerns getting out. And I think one of the things that has impeded that is safetyism. This whole idea of we got to keep ourselves safe, like the overwhelmingly in the what politicians are hearing at the door is about is the preservation of safety. Well, what's safer than staying in the house? What's safer than never going out? What's safer than not exercising because you could injure yourself? That sort of thing. So there's this real safetyism, I think, that's sort of come into permeated. That's the word. That's the verb I wanted. That sort of permeated the idea of inactive aging. Just one other quick anecdote. What I've heard around the table. When I go in to do some work for governments on design of benefits, like something like the Canada Disability Benefit, which is more recent, I'm introduced as a retired bureaucrat. However, less than 1 month ago, I gave an address to the Ontario Native Welfare Administrators Association, had many elders and chiefs and that had all come together for a grand powwow at on October the 5th. And rather than, which I still am a retired bureaucrat, rather than that, they asked me, after I'd sat down at one other table, to come up and sit with the elders, which I don't know if I like that much. I mean, I had sort of two minds about it, but I was sitting at the table of the people who were most revered, simply because of their positive view, I think, of aging. And when they would listen to me, they would listen to me thinking about, here's somebody, because of their age, is going to have more wisdom. I don't get any of that at all, believe me, when I go to Ottawa. So there is a real sense among Indigenous people, and we've heard that, have that far greater respect and value for the aging process. And so I just wanted to let you know that I felt it myself personally.
Brilliant. We now have time. I want to thank our panelists for this rich conversation, but we now have time to invite audience members if there are a few questions that people would like to pose to the panel. And I know my one friend and colleague, Mary, is always going to ask a question. Mary, please. And if you want to shout it, I don't know if we have a microphone.
I can shout very well.
And then I can repeat it.
I'd like to hear something about the fact that we tend to think in terms of workplace compensation for individuals to be able to continue working. But maybe we need to start thinking in terms of societally so people can continue working. Because yes, you can continue with an office job long after 65 for most people, but I don't know if I want the carpenter on my house to be someone who's 95. So we need to have more ways that people can continue in many more jobs, and we need to think of it societally rather than John wants to keep working, and what can we do to make it possible for John to keep working?
I guess that's
just that.
Thank you, Mary. I think so. Mary's question was really kind of thinking about, again, as we heard earlier, we have more people. Well, since we ended mandatory retirement well over a decade ago, we've seen a positive increase in the number of older people participating at all age groups. I think we heard loud and clear. I guess the question for Mary is there a way to encourage more people, especially when we heard that during the pandemic, one of the biggest negative declines are people choosing to retire early as opposed to staying in the workforce. Are there any thoughts from just any of the panel's members about what are the things we could do to encourage more people to participate should they wish to?
Yeah, I think that this really hits home in healthcare with the shortage that we have, and actually particularly nurses at this point. I mean, physicians have always been, but now it's really acute for nurses. And one of the questions was if people want to return to support, program, clinical program, and they have retired. But I think one of the issues that I think, and we haven't really examined it carefully, but that moral injury people had during the pandemic that make them want to leave work early. So I think convincing people to come back to a system that is burning people out, it's a risk that we're running now. So it really invites us to, I mean, I'm talking about the healthcare in particular because of the really alarming rate of people who want to just leave when they could continue to work and they're not even at the age that they decided to retire. And so to bring people back to that workforce at this point when we still have this tension and burnout is really an alarm for me as well. But obviously there's other sectors of society may benefit from this. In healthcare, it's a nightmare to convince people to come back when they're worrying about what's going to happen when they're there.
Jennifer?
Yeah, and it's not going to apply, obviously, as Mary says, across all different careers. But I think one of the silver linings of COVID, if you will, showed us that if you allow people the flexibility of their workday, and if you allow for accommodations, and if you embrace the idea that people can be anywhere in the world and working together as a team, for example, then it opens the doors for a lot of different opportunities, but also ensuring that there are accommodations. So even for sort of tele type jobs or at-home jobs, making sure that the office spaces are accessible, making sure that vision and hearing accommodations are accounted for across the board. Mobility challenges are accounted for, and do that in a way. I know I sort of emphasized this before, but with the lens of universal design. So understanding that you may have an aging workforce, and it's really common, for example, to have vision and hearing declines as a function of natural and healthy aging, but that will apply to a lot more people. Also work days, right? Making sure you accommodate for shortened work days. If you want people to come and share their reservoir of knowledge and to be these knowledge mobilizers and brokers, as many older adults are, then you need to make sure that you are accommodating their other desires to ensure that they are embracing their retirement or semi-retirement to do those leisure activities, to engage with their family and other things that they may have looked forward to as a function of retirement. So I think accommodation is going to be key. You're seeing a little bit of that already, but not enough.
I'll make a quick just addition to one of the ways that I've seen this working that I've been admiring and I would really like to see expand, and that's the phenomenon of intergenerational schools and intergenerational interactions being built into spaces like kindergartens or primary schools. There's folks I'm thinking of, Peter Whitehouse in the States, who is at the forefront of developing intergenerational charter schools that are, again, integrating the opportunity to interact between older and much younger members of society in a inclusive, familiar, school-based context that ends up having these ameliorative outcomes for younger and older alike. I believe there are some pilot programs that are beginning to happen here, that have that in place. But for me, the normalization of that intergenerational interaction would be one of the ways that work could be refigured to be appropriate and inclusive if physical issues or as Jennifer's saying, just whatever issues there may be, these other kind of care obligations mean that one cannot work anymore in the way that one might have between the ages of 18 and 40 or 18 and 65, as the case may be.
And from a benefit design perspective, 31% of Canadian seniors receive a benefit called the Guaranteed Income Supplement, sometimes just called the supplement. And you can earn $5,000 in a year before you will be subject to a 50% clawback of your income. So what's 5,000 bucks? Well, currently minimum wage in Ontario is about $29,500 working full-time, full year. So the federal government will allow you to keep roughly 1/5 to 1/6 of your guaranteed income supplement benefit before they start taxing it back at 50 cents on the dollar. Let's look for a second at the child benefit. There's no clawback of the Canada Child Benefit until someone's earnings reach $32,000. That is more than 6 times the amount where the clawback starts for the guaranteed income supplement. And just as a side note, when I was first told that the Canada Disability Benefit was going to be modeled on the guaranteed income supplement, I said, oh my God, let's hope not. It will have clawbacks on income above 5,000 or 1/5 of minimum wage. So maybe the design of the Canada Disability Benefit will start to lever something or wake up something in the design of that. And that speaks to work. People just make decisions to work based on how much money they're gonna lose from their benefit package.
Brilliant. I want to thank our panel. This has been a really spirited conversation. We did not need to coax anybody to share with us their opinions, but I want to thank again Dr. Burhan, Dr. Campos, Dr. Caris, and Dr. Stapleton here for sharing with us kind of their views so generously to really help kick off this discussion today about sustainability versus unsustainability. We are now moving into a break. And there'll be plenty of time if you want to. I'm sure our panelists are around for, I know you have a flight to catch shortly, but during the break, I'm sure our panelists will be happy to answer any further questions that you have. And again, I want to thank each of you for helping to prepare for this panel and helping to kick off an exciting day with a great conversation. Thank you.
During break, if we go on stage and film, go on stage during break and we'll film.
They'd rather stay home,
It's like just before Sorry, we're taking all the stuff. That's not even, that's taking over. No? Okay, I'll keep looking if I want to sit here. Oh, sorry about that. Nice to meet you. Yes. How are you doing? Very good. I really everything together still. Did you enjoy I know you didn't find good work going to home, and then you
successfully navigate Toronto's coming of age. Dr. Sidhan is the Director of Geriatrics at Sinai Health System and University Health Network. A Rhodes Scholar, he is highly regarded as a clinician and international expert in the care of older adults. He is also the architect of the Government of Ontario's senior strategy, and in 2014, his claim to fame, but claims proclaimed him to be one of Canada's 50 most influential people and his most compelling voice for the elderly. Dr. Sidha is also an appointed member of the Government of Canada's National Seniors Council and is also leading the development of the new National Long-Term Care Standards for Canada. Please join me again in welcoming Dr. Sidha to the stage.
Thank you very much again for having me and for inviting me to do this field presentation. I was asked to take this question on saying, can we actually navigate Toronto's coming of age successfully? And so I hope to answer this question. And you heard probably already my bias from this morning that I'm a pretty optimistic guy, and certainly having dedicated my life to caring for older adults, and certainly quite motivated to tackle this question and tackle it well, both practically and in this talk. One of the rules I've had with pride as well, at the bottom of kind of this list of things, is that the City of Toronto created its first senior strategy back in 2012. Mary over here is one of the members of our accountability table, which I co-chair with Toronto Seniors Advocate, Councillor Dr. Campbell. And so it's something that's been near and dear to our heart about how do we actually think about making Toronto a city where everybody can look forward to growing up and growing old. So we heard this question earlier today, why is enough? How do we actually think about aging? And it's interesting to see that the majority of our audience really felt that when we look at aging, we still think of it as a challenge, as a real problem that we still haven't yet solved. And so I think that's why we often use these kind of terms related to this concept of apocalyptic demography. When we think about these ideas of aging being a challenge, aging being a problem, and almost then taking that further to ascribing blame on the issues to older people themselves, and often seeing them as a drain on resources and net takers, not net contributors. I think you already heard in the panel this morning a lot about how we need to reframe or to transform the way we think about aging in our society, and how we can actually look at it in a more positive way. Often when we think about these terms, there was something that was done a few years ago called the Global Age Watch Index. It had 2 iterations, and it was a program trying to rank countries around the world where they had comparable data and give a ranking of where these countries stood in terms of becoming the best places to grow old in the world. And Canada did pretty well. We scored 5 out of 96 as the best country at aging. And of course, we had various politicians saying, see, we're doing everything right, we're in 25, that's pretty good. So we thought settled pretty well. But as we heard, what we know already is that when we think about older Canadians and issues that are concerning them, making it hard for them to thrive in our society, making it hard for them to feel they can participate and engage, is the 2 number 1 issues that remain the primary concerns for older Canadians are their health and their finances as well. When it comes to our finances, for example, you heard John this morning speak about some of these aspects of ways in which we can gain financial support. We heard about old age security. We heard about guaranteed income supplement. And one of the things that we get high marks for around the world is that Canada has a universal pension program. It's called our Canada Pension Plan or a Quebec Pension Plan. And 97% of Canadians receive a pension. That's great. So we're doing super well, and that's why we get really high marks. But when you actually look at the average Canada Pension Plan benefit,
I think a lot of people don't realize that currently that translates on average to about $8,700 a year. Now, of course, there's other ways in which you can shore up your income, but for a lot of Canadians, they're living closer to our low-income cutoff mark for older Canadians. So they're just above that level, but not necessarily much further beyond that. And so the question is, we know that for many older Canadians, finances remain a real struggle to especially support themselves in an era of increasing inflation and growing interest rates as well. So we also have another statistic that shows that the average Canadian without a workplace pension, so this goes beyond our Canada Pension Plan, but talks about people who may not be retiring with a pension if they worked, for example, as a teacher or an educator or worked as a healthcare provider. Many Canadians, the majority of working Canadians today, are not retiring with a workplace pension plan. And one of the most daunting stats that I've come across is that average Canadian without a workplace pension plan is retiring with a median amount of savings of $3,500 in the bank when they retire. So it also speaks to one of the reasons why Canadians have to spend often longer in the labor force to try and make up those income gaps so they can continue aging as well as possible. Another aspect is that Canadians get very high marks because we have one of the highest and longest life expectancies in the world. That's really good. But when you ask Canadians what they're most concerned about in terms of their overall health well-being, the majority say that they're concerned about having access to quality primary, acute, home, and long-term care services, basically healthcare. And they're not just talking about having access to it, they're talking about access to quality care as well. So certainly we've heard a little bit about some of the work that's happening in Eastern Toronto with the Scarborough Health Network, with the growth of the new medical school that will be based here as well. And we often think about how do we actually think about building a healthcare system that works well for all, and especially for those who often are some of its greatest users. Because if we can solve these two issues, if we can solve ways to actually help people better support them with their health and their finances, we know that older people want to remain productive and engaged and want to be experiencing more of what they would consider a triumph rather than potentially feeling that they are part of and experiencing this feeling of being part of a tsunami as well. So I shared with you some of the statistics, but I'm going to give you a little bit more of an overview of the statistics related about aging, really to help frame where we're thinking about where we are in Canada, and then specifically where we are in Toronto as well. So I mentioned that where Canada's population was, but I want to kind of share that when I moved back to Toronto in 2010 from the US, Canada was still a relatively young population compared to where it is today. So in 2011, 15% of Canadians were 65 and better. And so again, it was still a relatively small minority, but that was the year we started focusing on the needs of our aging population, because that was the year that our baby boomers started turning 65 and older. And as you heard today, this is a group that we've known about for many years, but we know that this is a group that is particularly going to need more health and social services over the coming few decades as they age through. So in 2011, we were 15% of the population, 65 and better. And between then and today, we knew in 2016, older Canadians started outnumbering younger Canadians for the first time ever in our history, and will do so for the foreseeable future. So where do we stand today? Well, 19%. So almost a quarter of that population now, or this population has grown by almost a quarter, from 15 to 19% within 1 decade alone. And so when we think about our population and how, for example, our older population, representing a minority of it, represents itself in terms of hospitalizations and other healthcare utilization, we know that this small group, 19% of our population, currently accounts for about 42% of our hospitalizations. We also know that when we talk about days in hospital, we know that older people tend to stay longer than younger people in our hospital settings. So we know, again, this small minority represents 42% of our hospitalizations and close to 60% of our overall days in our hospitals as well. Now, we also know that when we start thinking about older users of healthcare, you could imagine that, well, with these statistics and kind of with what I've been sharing with you, it's rightful to think that the future students, at SAMI will actually be thinking that, well, when you're old, you probably sell your home and then you go live at Scarborough Health Network. You go live in the local hospital because that's where all the older people are, right? I mean, you don't see older people out in the community because all you see as healthcare students every day is older people all around you. So that's where they are. But I think that, again, really skews kind of our view because as healthcare providers, and certainly as a young trainee myself, that's kind of what I believed because I moved to Ontario for medical school. And I'm like, wow, like just older people all around me in healthcare settings and so on. So I guess this is what happens in Ontario. This is what you do. But it's really important to actually look at that data, look at the data a bit more closely. And I think John said that well, is we often have these ideas in our head, but they're not necessarily based on data. They're based on our experiences and our philosophy of what we're looking at. And this is one stat that really kind of helped enlighten my thinking. It was that 10% of older adults are responsible for 60% of the healthcare spending amongst older Canadians. So about half of our healthcare budget today, our budget now is closer to about $70 billion in terms of what we're spending. So we're saying about half of that budget, about $35 billion in Ontario alone, is accounted for by older people, but only 10% of our older adults represent 2/3 of that $35 billion. So again, it's really a small percentage of the population, of our older population, that are significant users of our healthcare services. And by appreciating their needs or appreciating what are the structural barriers for them to stay healthy and well, we start realizing that there's often three factors that characterize this population. Number one, it's probably having what we call economic and social fragility. So you may not have the finances to afford the additional supports you might need, or even the finances to take a taxi to go and see a local healthcare provider, or to get your groceries, or to do other things. You may not have family members or friends who are available to help you with a basic task like getting a prescription filled or doing that. And we know that 25% of older Canadians tell us they don't actually have someone available to help them with those basic day-to-day tasks. Another aspect is living with multiple chronic health issues. We know that the average older person who is in our hospital is living with multiple chronic health issues. And the definition of what we call polymorbidity or multimorbidity is having 4 or more chronic conditions. Now, I'll tell you, if you have a condition like congestive heart failure, you probably already have underlying heart disease. You probably have high blood pressure. You probably have high cholesterol. You may have diabetes, for example. I've just named for you 5 things, and you just need 4 to be in the club. So all of a sudden, you start realizing that many of our oldest users are what we call multimorbid or polymorbid patients. And again, how are we thinking about their issues, not from a one issue, one visit kind of approach, but really thinking about how all those issues might interplay. And finally, we often neglect the fact that many older adults, not all, but there are a number of older adults who are often experiencing functional challenges. So challenges with their cognition, for example, or physical challenges, challenges with their activities of daily living. And to remind ourselves, our basic activities of daily living are the 6 things you had to do probably to be able to get here this morning. You had to, number 1, transfer yourself from a lying to a standing position. You had to be able to ambulate around, to walk around. You had to be able to bathe yourself. You needed to toilet yourself. You needed to dress yourself, and you needed to eat something. And if you're struggling with one or more of these basic, what we call activities of daily living, it's really hard to exist independently. And then you think about those higher order tasks like arranging transportation or taking one's medication. So we know that this is a group that is highly challenged. But if we start understanding what those needs are, then we can start thinking about the things we can do to better support these individuals and also lower the overall costs of caring for them overall as well. We also know that our health system has not been right-sized for our aging population. So one of the things we've heard quite recently is this challenge that we are now in Ontario at a record state of what we call ALC numbers, or alternate level of care numbers. This is the idea of Canadians and Ontarians being stuck in hospital every single day. Across Canada, that number is around 7,500. We've been heard recently that right now, currently about 6,000 people in Ontario are stuck currently in hospital. 40% of them are waiting for long-term care, but the other 60% are not necessarily waiting for a place in a long-term care home. They might be waiting for basic things like home care in their own homes, or waiting for a space, for example, in a rehabilitation hospital so that they can recover and return back to their communities as well. So we often know that these are individuals who are stuck. And when I talk about this in countries like Denmark, where they don't actually have an ALC problem because they've actually right-sized their system, I remember describing this problem to one of them because they never heard this term called ALC, or in Britain, the term that's often used is bed blocker, for example. They said, well, why would you hold your citizens hostage? Why would you hold them against their will in the hospitals when they probably have their own beds in their own homes? And we solve this by making sure that we advocate for more home care, because there's many things you can do to support people in their own homes. And if they had more home care, they probably wouldn't need to be in a nursing home. Have you thought about that? I loved it when they said that to me in particular, but more importantly to all the deputy ministers from across Canada who accompanied me on this trip and who needed to hear this from her. So when we also realize what the costs of waiting to go elsewhere are, we know that it's been ascribed at one point to about $2.4 billion. So this is not a non-costly endeavor. You can imagine that the cost of just waiting in hospital alone on a given day can be quite significant. And so there's a cost to this problem when we haven't right-sized our healthcare system to be delivering the care that older Canadians in particular both want and need. We also know that our population continues to age. I showed you how we've gone from 15% in 2011 to now closer to 19% in 2021. And within 10 years, we know over this decade of healthy aging that we were talking about, within a decade, about a quarter of our population will be 65 and older as well. So again, we know that we are continuing to age, but the question is, how prepared are we? Because really, perhaps what I'm presenting to you is a real picture of unsustainability when we haven't figured out how to actually create the right mix of services to better support people. So I showed you this headline. What I didn't tell you was actually, I wrote this with the CEO of the Ontario Hospital Association right before one of the budgets that the Ontario government released. I believe this was probably back in 2014 or 2015. You know, the ministers of health and finance weren't very pleased that the Star held on to this commentary and published it on the day of the budget, for example. They only wanted positive news, but we said, really, we didn't really see that there was much in the budget that was really focusing on making sure that we were right-sizing our healthcare system to better meet the needs of the aging population. So we said we weren't criticizing, we were just making an observation, and they backed off. Anyways. Of course, you know, then you always get concerned because politicians are always trying to look for quick, easy retail solutions. And this was a clip because we know that the current government, for example, got elected with a commitment to build 30,000 new beds, but they were sadly not the originator of that idea, which I'm not super excited about. In fact, it was the previous government that decided, wow, we're not sure what we can do. Let's build 30,000 more beds, because at the time we had 30,000 people on long-term care wait lists. So I love this picture here because here's the finance minister at the time, you know, announcing this, and here's everybody, you know, in the cabinet, you know, giving a standing ovation saying this is the solution. So I'm going to ask an interactive question without using Mentimeter to the group here. How many of you in this room aspire to end up in a long-term care home? I think the microphone is broken and everyone's gone to sleep. I'm going to ask again, how many of you aspire to end up in a long-term care home? Please raise your hand. Right. So, you know, pretty easy. I kind of knew the answer to that question. It's that really nobody aspires. It's not to say that there is not a role for long-term care in our society. But again, this is something that people don't aspire to. And so really, is this a solution that we should be promoting? Is this actually in line with people's preferences, needs, and values? I would say not. So how do we look at this differently? So here are some of the top 5 barriers, system barriers to integrating care for older adults, things that I've observed over the last decade or so in as a geriatrician here in Toronto. Number one is we do little to empower patients and caregivers with the information they need to navigate the system. Often, you know, I have older patients and their families just asking about, what are the financial mechanisms that are available? Are there things to help renovate our houses or do other things? Are there, I heard that question asked earlier today. Are there, what are the different healthcare systems? How do I access home care? I don't know how to do any of these sorts of things, for example. So we make it really hard for people to navigate our system or systems, for example, or lack of a system overall. And that really disenfranchises people who often very much want to navigate things on their own as they have throughout their lives, but feel very disempowered in a system where they're not really sure how to navigate new issues. Number two is, one of the biggest challenges I have is that we don't require any current, future, or health or social care professionals really to learn about the care of the elderly. So if you look at the programs in the medical schools across Ontario, for example, and the majority of schools across Canada, for example, you'll find that every medical student in Ontario is required to do mandatory training, clinical training too, in pediatrics. I've been teaching at U of T for over a decade in the medical school, and we are still fighting to get geriatrics a place on the clinical curriculum. Often being told, well, most people that medical students see are old, so they'll learn about old people through osmosis, right? And I'm like, hey, we don't make that argument about pediatrics. We know they're not little people. We know that they're physiologically different. There's different approaches to their care, and it's the same issues with older adults. So why don't we actually mandate this? I'm hoping that with Sam IH and I know that with advocacy, we are on the verge of finally getting a geriatric medicine clerkship at U of T after over 100 years in existence. So anyways, something that I think we need to be doing more of to make sure that our future health and social care professionals are really empowered. We also don't really tend to talk to each other well within and between sectors and professions. So often we're trained separately, and then we often kind of work separately. Often we find that healthcare professionals don't appreciate what the others do, even within an organizational setting, let alone between sectors and professions. So I have the privilege, because I do home visits, for example. I work with home care providers regularly. I work in So I actually have a very unique perspective about how older people need to navigate and the challenges of navigating parts of the system. So I get how things work from a systems perspective, but often a lot of my colleagues in these individual parts have trouble communicating between sectors and between professions. And often that creates a challenge, because often then we're working in silos and not as an overall system as well. The other challenge is that we often plan for today and not really for tomorrow with regards to understanding the mix of services we should invest in to support sustainability. So obviously we heard that some of the goals for Eastern Toronto are really thinking about the role, for example, of the Scarborough Health Network, that SAM IH can all play in this overall future of caring for really what will be an aging part, a significantly aging part of our city, and one that we need to think about these issues if we want to create an overall sustainable healthcare system as well. So I often think about older patients, and this was one of my very first patients that I met when I moved to Toronto back in late 2010. This was Mr. W. At the time, he was. This was taken on his 100th birthday. I did a home visit with his home visiting physician. And again, he was a person who I had met when he was still 99, and I met him during his 7th hospitalization of the year. Because while he was quite independent, cognitively intact, you just need to look at the Rubik's Cubes, which are not for display. They were things that he played with every day. But here was a guy who, was doing quite well at 99. At 93, he learned to use a computer. He was staying quite active and engaged, reading his books, participating out in his community. But at 99, his arthritis, his CHF, his COPD all started to actually converge and then make it harder for him to stay healthy and independent. And he could no longer get out to a walk-in clinic or to a clinic-based physician to go get help and support. So now the only thing that he could do is wait till things got bad, call 911, and he'd visited pretty much every downtown hospital at least once by the time I met him in September of 2010. And really, it really reminded me about how there were so many things that we weren't doing right to help someone like this kind of stay healthy and well. So the question that I ask is, we can think about older people in our lives right now, and how ready are we to meet the needs of aging individuals, especially those who want to stay active and engaged members of their community. So the challenge is that our dilemma is that the way in which our cities, our communities, and our healthcare systems are currently designed, resourced, organized, and delivered often disadvantages older adults with chronic health issues. But as Torontonians, our care needs, preferences, and values are evolving as a society, with increasing numbers of us wanting to age in place. So how do we reconcile that difference? How do we actually figure out a way to challenge this and better make our systems more sustainable? So we need to also remember that there are aging-related changes, for example, that first of all define us all. People often say, how do we prevent aging, or how do we cure aging? And I think the key is that we have to embrace aging, but we have to appreciate that there are natural changes that will occur to us as we all age, and it's important to start thinking about that. We know that for many people, 25% of older adults will be living with visual impairments, for example, some that can't be corrected. And so we need to think about that. We need to think about 25% of older adults can be experiencing hearing loss as well. And we heard already from this morning's stat that that's one of the most modifiable things we can do to actually prevent the onset of a dementia, for example. So these things matter because, again, if your vision and your hearing are challenged, it can make it harder for you to navigate your spaces safely and feel as comfortable navigating in community settings. We also know that as we age, there's an increased risk of developing a dementia. Age is the #1 risk factor associated with developing a cognitive impairment over time. And while we know that more and more people will experience what we call normal age-related memory loss, there's experiences of what we call mild cognitive impairment or dementia that can occur. And so how are we going to be able to better support people experiencing cognitive changes to help them remain healthy and independent? As one of our colleagues mentioned this morning, that that often people get a label of dementia and then people say they shouldn't be driving. It's not quite correct. For example, people living with a mild dementia can still be quite a good and capable driver. But again, how do we ensure that there's enough supports so we can allow people to maintain their capacity until they no longer have it as well? And also the other issue is we start developing skeletal and muscle changes. So many of us have heard about osteoporosis or osteopenia, where our bones will actually weaken over time. Usually they peak in their strength in our late 20s, but we know after that they start to weaken over time. And same with our muscles. We often experience something called sarcopenia as we age. That's why it becomes really harder to do this. That seems very basic, but you can realize that with your biggest muscle groups, your glutes and your quads start to weaken as you age, for example, it can be hard for people to independently stand from a chair, for example, and to move around without needing to recruit additional muscles as well. So knowing that these are natural changes that can occur, but there are things that we can do to modify these risks as well, is helpful when we think about things. Just to give a perspective, for example, when we think about vision loss, I want to give you an example because often, people hear about loved ones having things like cataracts, macular degeneration, or glaucoma, but I don't think many people appreciate what that might actually be like. So this is a photograph where you see a person who has normal vision. Now, this is something that you would see if your loved one has a cataract, for example. Or this is what it would be like if you potentially have an age-related macular degeneration. And then this is what it would be like if you were living with glaucoma. So now appreciating that 25% of older adults might be experiencing vision loss, how do we think about the font sizes that we're actually using? Are we thinking about the contrast that we might actually use with things? And again, if we're making street signs that have very small lettering or other signs with very small lettering, we can appreciate that these small little details, for example, can make it harder for people to feel comfortable successfully navigating their worlds, especially if they're living with a condition that can no longer be corrected as well. And so when we start thinking about where Toronto's aging population are living, I like this title that was from CBC News a few years ago. They said basically nearly everywhere in the city, a new report finds. And I don't think this should be terribly shocking, but I want to share with you some of the data specifically to Toronto. So back in 2012, there was a a group that on behalf of the city created some population growth forecasts and really talked about what we can forecast our population growth to look at between the years 2011 and 2041, so this 30-year period. And what you can see is that between 2011 and 2041, our older population is expected to double overall. This is the population 55 to 85 and above, if you will. And what you see is that while this population of 55 to 64 years of age will stay relatively constant in terms of their proportion, what we see is the greatest growth in the upper bars, the blue, the red, and the gray bar, that shows a significant growth in that population 65 to 74 years of age, 75 to 84, and 85 and above. And what we know is over a 30-year change, we're going to see this population grow by 76.2%. So we need to be ready to appreciate how quickly our population will grow. This is one of the an image that our social policy analysis and research unit at the City of Toronto created to kind of also show where the most dramatic growth is occurring. This was actually a chart that showed where our population is aging the quickest between 2001 and 2011. And when you think about the region where we are in right now, you can see this is one of the fastest aging segments of the population, yet also one of the most underserved segments of the population when it comes to not only healthcare services, but also community support services and other things that are really important for older adults. So again, not massive numbers, but we've seen a significant increase between 2001 and 2021 amongst our population 65 and older just alone. And again, this is a population that's going to continue to increase, but our 65 and older population has increased over the last 20 years by 41.2%. So we also know that older Torontonians are a diverse group. Almost 3 in 4 older Torontonians were born outside Canada. We know that 1 in 3 older Torontonians is racialized. We also know that older Torontonians speak over 150 different languages, and 37% speak a non-official language as well. So they're not speaking English or French. So again, how do we think about how we're delivering our healthcare services and other supports to help older people live in place? And I'd argue that here in Eastern Toronto, these stats are probably even more pronounced, for example, than what I've shown you for the city as a whole as well. We also know that there are other forms of diversity other than just race and gender as well. And we can think about sexual orientation. From our recent Stats Canada work, we found that 4% of Canadians 15 years of age and older self-identify as being from our LGBTQ plus community as well. And we know that, and again, this is a population that continues to age, but the aging segment of this population is particularly vulnerable for a number of reasons. We also know that when we think about physical activity limitations, and we heard a little bit about this from some of the discussion this morning, that 50% of older Ontonians live with an activity limitation or disability. We also know that 10% of adults 65 years and older live with dementia, and this rises to about 1 in 3 people above 85 years. That's why we're most concerned, especially about our population 85 and older in particular, because we know as our population not only chronologically matures in age, for example, but we know that this is a population that's more likely to live with things like dementia, which have significant care and implications. We know as well that 34% of older Torontonians live alone. And we also know that 25% of adults 85 and older are living in congregate care settings like a retirement or nursing home, yet we already know we have a shortage of these spaces as well. So finally, when we think about people living in poverty, we have to also reflect on, again, the challenges of aging for many Torontonians, because right now we know that 17.4% of older Torontonians live in a low-income household. We also know that racialized and immigrant older Torontonians are twice as likely to live in poverty as well. And 90% of Indigenous older Torontonians are living in poverty. So we have to, again, remember that that these issues of low income are not necessarily universally shared amongst our population, but might be more significant in this part of Toronto when we think about the underlying population that calls us home. And right now, when we think about affordability, especially when we hear about the increased cost of housing, but also many older Torontonians who are currently renting where they live, we know that 1 in 5 older Torontonian renters spends greater than 50% of their income on their housing costs alone. That doesn't leave a lot of extra money aside for paying for other things, such as food or for health and social supports as well. We also know that COVID-19 has shifted our perspectives. We did a study through the National Institute on Aging that really focused on the question as to have people change their opinions about where they want to age. Well, first of all, 91% of Canadians of all ages and 100% of Canadians 65 and older said that they plan on supporting themselves to live safely and independently in their own homes for as long as possible. The key is when we ask people whether they would consider for themselves or a loved one to move into a long-term care retirement home. This was in June of 2020. 60% of Canadians said they've re-examined their thinking around that and said, no, they really don't want to ever live in one of those settings. So people are more determined than ever before to stay in their own homes. That's why the federal government recently announced, you may have heard in their election pledges as well, that they want to create a national aging well at home or aging at home benefit, for example. John is certainly a benefits expert, but again, this is another thing that the government's thinking about how do we support more people to age in their own communities when this is overwhelmingly what older Canadians and older voters actually want. So how do we advance an age-friendly Toronto? What are the ways in which we can think about this? When we think about the definition of age-friendly cities or age-friendly communities, the World Health Organization made this one of its actual areas of focus back in the 2007 to 2009 period, and created a whole program called Age-Friendly Cities and Age-Friendly Communities. And I really love this definition because it talks about a community that recognizes the great diversity amongst older persons. It promotes their inclusion and contributions in all areas of community life. It respects their decisions and their lifestyle choices, and it anticipates and responds flexibly to aging-related needs and their preferences. And what I like about this is that when we talk about age-friendly cities or age-friendly communities, it's not just talking about it from the perspective of older people, but you'll notice that there's no age represented here. This is talking about a city for people of all ages. The idea of, you may have heard of the 8 to 80 Cities Initiative, the idea that if the city is good for an 80-year-old, it should be good for an 8-year-old, for example. This idea of universal design and universality to make communities more responsive to the needs of people of all ages, taking that idea of a life course approach. So when we think about, well, what are the pillars that represents kind of an age-friendly city or an age-friendly community? Again, this is what the World Health Organization came up with as an originating framework, thinking about these 8 aspects that all work together to create this concept of an age-friendly city. So as I mentioned to you, Mary and myself and several others have been involved for a number of years now, because when I was invited to develop Ontario's first senior strategy in 2012, and then again in 2017, what the City of Toronto said was, well, we want to create our own strategy as well, something that can complement and work on partnership with the provincial strategy as well. So this was actually the cover of our very first senior strategy released in 2013. We then actually created a second senior strategy in I believe it was 2017, for example, and we've now completed 2 successful strategies, and these have always been unanimously agreed upon by council. It's one of those lovely things where I'm like, no one's ever going to vote against this, and it gives us permission to actually do a lot of great work to shift things forward in particular. So what were some of the creative elements that you think about as an age-friendly city? Number one is this idea of respect and social inclusion. It really asks the question, are public services, media, and faith communities respectful of the diversity of the needs amongst older persons and willing to accommodate them as well? So thinking about how are we making sure that all of our institutions, and I wouldn't even say public, but public and private services, everything that we're doing, are they thinking about who our customers will be, who our clients are, who are the people who engage in our spaces, and are we actually making sure that we're thinking about their needs and how we can accommodate them better so that they can feel included as well. When we talk about social participation, are we making sure that older persons have opportunities that allow for the development and maintenance of social networks within their neighborhoods as well? So how can they feel that there always are going to be ways in which they can stay engaged and included? And one of the things that we did provincially, for example, and then the city certainly took advantage of here was my recommendation to the Ontario government was to expand the number of what we call seniors active living centers or elderly person centers. So we had something like 250, and what the government did was it actually, in response to our first senior strategy, put out funding to expand the number of seniors active living centers. What I liked was recognizing that diversity lens and that lens of where we actually have disparities. And so what we were able to do is actually create a framework. So we announced a number of these new centers, but we're going to be located in areas. I remember reviewing the applications, all of them, and ranking Eastern Toronto and parts of Mississauga and others as places, for example, where we actually need to see more of these centers, for example, especially from emerging communities that wanted to actually create programming that could meet the diverse needs of older populations as well. So again, one example, because we know these can be ways where people can get together and share in programming that's developed by them and for them as well. This is one of the very cool things that, that we developed in partnership with the City of Toronto Library. So they're part of the accountability table right from the beginning. And they've come up with a whole bunch of cool initiatives, for example, to support inclusion and participation by older adults. So they actually now have a course they run across their libraries that actually support older people around digital literacy. So again, people who are wanting to use Facebook or wanting to just surf the internet, get access to the internet, for example. It's programs like this that have actually been quite successful and quite popular for older adults in free settings where many older people are engaging. What was really cool was during the pandemic, the libraries, I love our libraries here, they were so into their role as part of the City of Toronto Senior Strategy that they decided, when they realized that the pandemic was affecting so many of their older library patrons who were isolating at home and couldn't readily engage, our librarians decided to call all members of the library who are 80 and older for a wellness check. How are you doing? How are you feeling supported? Just to let them know that they weren't being forgotten, that they were being observed. And then I was able to help engage them with the help of Councillor Matlow to really kind of help us when we had our COVID-19 vaccine rollout. I said, you called 30,000 older people. Could you do it again now that we actually have a vaccine, and make sure that our older folks know how they can access clinics and support should they need them, or even get a homebound vaccination from our community clinics. When we think about other aspects of an age-friendly city, we think about the idea of civic participation and employment. Do older persons have opportunities to participate in community decision-making and employment, and volunteerism that caters to their abilities and interests? So when we think about kind of, again, what older people want to do, we heard a lot. People want to stay engaged in the labor force. They may not have choice, but they actually have to work to earn money. But how easy do we make it for them to participate in flexible ways, in ways that will really encourage them to want to participate? How do we recognize that older adults are some of our greatest source of volunteers in our society? If we think about Scarborough Health Network, if we think about probably UT Scarborough, for example, we probably have a lot of older volunteers. And certainly when we had to restrict a lot of those activities, we found that I read a headline the other day that in Saskatchewan, a lot of services are in crisis. A lot of services are in crisis. Community services are in crisis right now because they really relied on a whole army of older volunteers who are no longer as readily available. So how do we think as well about our outdoor spaces and buildings? And again, thinking about how can older persons get around easily and navigate safely in their communities? So one of the cool things that we did with the Parks and Recreation Department is we actually created a plan where they installed 2,000 new park benches closer to where older people are living in high density settings, or including things like retirement homes and long-term care homes. And this is the official new park bench that the city has been rolling out in some of its newer parks. And I want to ask the question is, why does Mr. W prefer this park bench? So I see, yeah, I see some people saying, because it's got those arms, for example, again. So when you think about, arms on a park bench, for example, and how this has been creatively designed, this actually allows people to actually have a good, stable support so that they can lift themselves up, whether you're pregnant or whether you're older and have actual muscle, if you will, weakness, for example. But it's also meant for people who might be in wheelchairs as well. So it also thinks about, if you see, there are two arms, and then towards the right side of the bench, there isn't an arm, because there are people who might be living in a, not living, but actually moving around with a wheelchair, and they can actually lift down the side of a wheelchair and then be able to slide over. And actually, it was Dr. Campos's colleagues, Dr. Jeff Burney and friends, who we solicited and said, what is the right dimensions of a park bench? And they had the team at Kite work on it, and they came back, and that became the specs that we said. Again, what are the little things we can do? And so I always giggle every day when I see a new park and I bike by and stuff, and I'm like, yep, there we go. And it just shows these little things can make such a big difference to make our cities more accessible as well. When we think about housing, do older persons have homes that are safe, affordable, and conveniently located while promoting their independence, as well as their functional needs change? And then how do we think about transportation services, and can older people travel to wherever they want to go in the community safely and in an accessible and affordable way? Some of the cool initiatives that the City of Toronto has been working on, for example, is a home sharing initiative, allowing an intergenerational way that older people who might have a spare bedroom in their home can actually allow, say, UT Scarborough students who are looking for a more affordable place to live, can actually live, and in exchange also be providing some supports that allow an older person to age more confidently in their own home. We have programs that many people don't know about. One's called Ontario Renovates, for example, or other services that can allow people like my patient Barbara, for example, to actually get kind of a lift added onto the front of her home that could allow her to age in place. Barbara was able to stay at home. She was able to die at home. That was her wish, for example. But until we had this lift, she could never leave her home. And this is why these sorts of important renovations, for example, were all she really needed, and certainly much less costly than having to move into a long-term care home as well. We also have a whole program in Toronto. It's actually called Scarborough Ride. Overall in the city, it's called Toronto Ride. And again, this is a service for people who don't qualify for Wheel-Trans, but still need to get around, for whether it be hairdressing or a shopping visits, for example, or medical and other appointments. So for those individuals, they can actually have this door-to-door arm-in-arm service, for example, especially if they may have mobility limitations that make it less easy for them to access traditional transportation as well. Finally, how do we think about our communication and information systems? Are older persons and their families aware of the diverse range of programs and services available within their communities and communicated to in accessible ways? And how do older persons have access to social and health services they need to stay healthy and independent? Again, thinking about the important roles that all of these things do to play in creating an age-friendly city. One of the programs that we really launched well in Toronto, it now has a team of over 15 full-time paramedics who are part of it through Toronto Paramedic Services, is called Community Paramedicine. In fact, the Toronto Star did a whole article about it, our first pilot project back in 2014, and they actually nicknamed it, I really like this, Heels on Wheels. And again, it was the idea of having paramedics visit their clients who often were calling 911 on a significant basis for non-urgent issues. In the first year alone of our program, for example, they were able to visit with 500 individuals who are often calling frequently for non-urgent issues. And by actually working with them, I trained each of them how to do a mini comprehensive geriatric assessment, how to actually better connect people to home care services, to community support services, etc. And by doing that, they were able to cut 911 calls by 49%, and they were able to decrease transfers to emergency departments by 67%. The mayor was so impressed by this program, he's like, we're going to put more funding into this, because again, this was a way that the paramedic services said, we can actually have more capacity to serve people in emergencies better, but we're also better supporting people who really need to be connected to other forms of care to stay healthy and independent as well. So how do we enable more care at home? Well, one of the things that I focused on, because we don't actually have it, is a national senior strategy. The important that we need to think about supporting people, Canadians overall, to think about how they can independently, productively, they can remain independent, productive, and engaged citizens. How do we support people to lead healthy and active lives across the life course? Not just, as we said, when we're older, but things that we can do at a younger age to help stay healthy and well. How do we enable more care closer to home? And how do we enable more support for caregivers, often forgetting that 8.1 million Canadians are serving as unpaid caregivers, and a typical caregiver for someone living with dementia on average is spending 26 hours a week providing that care. That's almost a full-time job. So again, when we think about ways in which we can provide care or better long-term care services, and these are some of the reports that we actually created back in 2019 prior to the pandemic, that really helped look at best practices from across the country and around the world, but also looking at the future costs of care and what that will look like if we don't do nothing. And frankly, we said we can't afford to do nothing. So I shared with you earlier that right now we have so many Canadians who have unmet home care needs, and it helps to understand why we have so many people who are on our nursing home wait list. Because right now, CIHI, our Canadian Institutes of Health Information, says that we probably could support between 10 to 30% of those moving into our long-term care homes currently to remain in their own homes if we had adequate home and community care supports. So it's reminding ourselves that, do we need to be building so many beds, or do we need to actually be making sure that we have more home and community care services available? And for those policy folks who say, well, you know what, why are we actually putting more funding into supports and services? Let's just rely on the kids and the spouses. They'll settle up the score. Well, we have to remember that with declining birth rates in our society, we actually know that we are going to have 30% fewer close family members and friends available to provide unpaid care, 30 years from now. So this is not a sustainable option, especially if we're not doing our best to support caregivers who often are providing billions of dollars in unfunded care, but at growing rates of distress to them as well. I'm not going to go through this diagram, but in that report that I talked about, Enabling the Future of Long-Term Care, we talked about there are things that we can do right from when people are staying healthy communities, concepts like age-friendly communities, things that we can do to make housing supports even more affordable for people to remain in their own homes and their communities, the things that we can do as people progressively might encounter more health and social challenges. So we really went through a bunch of really innovative things where people have done some creative things. And I would say a lot of the answers are out there. And sure, we should do some more research and development, but I often say we could spend a lot of time doing R&D called rob and duplicate, right? People have actually figured out some of these ideas quite well. So why don't we actually just go ahead and implement them? Because we know there's really good evidence supporting many of these ideas. So I want to finally talk about how the fact that we have choices and options, because I talked about how in Denmark, when they heard about our challenges, they said, why are you holding people hostage? Because it's a costly endeavor as well. We know that waiting to go elsewhere, so if you're an ALC patient on an average day in an Ontario hospital, it costs the hospital about $750 a day. If you're in a long-term care home, it's about $200 a day. But if you're receiving home care for a long-term care equivalent person, our own Ministry of Health says it costs about $103 a day to provide home care for a high-needs individual, for example. So you can see actually where the differences are in costs here. And I mentioned Denmark a few times because we know Denmark actually avoided building any new long-term care beds over 2 decades and actually saw the closure of thousands of hospital beds by strategically investing more in their home and community care services. And so one thing that I had recommended back in 2012, or earlier than that actually, was that we actually accelerate increases to our home and community care budget by at least 5% on an annual basis. This is at a time when we were increasing hospital budgets by 0% and even decreasing physician budgets overall to help pay for more home and community care investments as well. And did that actually have any effect? Did this kind of Denmark approach actually work? Well, one thing that the current government doesn't like to talk about is what the previous government did. They'll often say that between 2011 and 2018, they didn't build that many new long-term care beds, only 611 beds. They neglect to mention that there was probably over $1 billion increase in the home and community care budget. And so just to orient you, the blue bars represent those people who are 75 and older living in Ontario long-term care beds, about close to 77,000 people. And the purple bars represent older adults who are 75 and above who are high needs home care clients. So they're actually all long-term care equivalent individuals. And what you can see is the purple bars start to outnumber the blue bars. In fact, today, our latest data from the ministry says that there are about 131,000 older people who are staying in their own homes as high needs home care clients, compared to the 76,000 older people in our long-term care homes. So it reminds us that there are actually community-based solutions that if we did more to invest in, we could actually create more capacity. So finally, for those younger folks in the room or those who are interested in advocating around these issues a bit better, I always say when you're thinking about an issue, know your issue's jurisdiction and who can solve them. Because certainly when we started developing the City of Toronto Senior Strategy, we looked at how previous strategies often aren't successful when you're actually talking about things that aren't even in your own jurisdiction. So we really focus our Toronto strategies on things that are in the Toronto's remit to actually figure out, but then advocate to other levels of government for things that they can do. So in our very first strategy, the only thing that we weren't able to move on was low-income seniors dental. But you will know that we made it an election issue for the 2018 provincial election, and now all older Ontarians have actually access to low-income seniors dental. So these issues can be federal, they can be provincial or municipal, or they can be a mix. And understanding which part of government you need to advocate for can be helpful. I always say do your research and know your facts. Often people will listen more when they think that you know the problems and issues well and you have some helpful answers. It's not just great as an advocate to say, here are the problems, here are the problems, here are the problems. Politicians want to be champions. They, government officials want to solve problems. So if you come to them saying, I know this is the problem, but I've got an answer for you and I've got evidence to back this, for example, people are going to listen up and pay more attention. I always say find ways to make things relatable. So again, many folks in here have different roles that they play, whether they're healthcare professionals or have other roles. And so whenever I'm speaking to a politician, quite often, I'm always like, your older voters, remember, older people vote. They're the most engaged voters in our society. They're concerned about X. Or as a physician, I can speak to what I see on a daily basis. I see this issue every day. This is a growing issue, and this is how you need to. Again, all of you have a unique perspective, and that is an important perspective to really share why your views are important and what you're seeing. And I always say if you can make the issues, if you can make your solutions highly retail, they often sell well. So make your solutions easy to understand, easy to comprehend, and figuring out ways to articulate them in an easy to communicate way, because often you'll get more uptake around that as well. So finally, developing age-friendly cities and healthcare systems requires a shift in traditional thinking. And we know that age-friendly cities value older persons, they ensure responsive planning, development, and design, and they build relationships often through effective communication. And I was really proud that in 2014, Toronto, the City of Toronto, actually earned its kudos from the World Health Organization by being declared Canada's largest age-friendly city. And it's something that they have to continually renew and prove that they're making progress to hold that designation as well. And that certificate, I believe, still sits in the lobby of City Hall, for example, to remind us of what we've achieved, but again, what we need to continue doing. And programs only succeed through collaborations and partnerships internally and externally, and small changes can make an enormous difference. So often we think about the people that we brought together today in the room. We're talking about bringing academia together with a local health system, using a medical school as a basis to help also to be a catalyst for change. There's so many exciting partnerships and opportunities that can come out of a day like today, and I'm glad this is part of an overall dialogue that's occurring. And finally, just remembering that age-friendly cities can, in my view, ensure the sustainability of our communities for years to come. And so why I think we need to think more about this and why this is really our time to lead. So I'll stop there, and I want to say thank you very much, and I'll invite one or two questions as well. Yeah. So do we have, is there any question at all? I'll also be here during the lunch break as well. We've got a question over here.
Thank you so much for a great presentation. My question is about, so there are some great solutions there, and I think we've made some great strides. But I still think that there is a pretty big gap between all the research that we have found and like compelling findings, programs that work, and then actually translating them, as you were saying, into programs that are effective and actually work. How can we close that gap between researchers and policymakers and actually make a difference? Because as you talked about, this is a glacier that's been going on for so long. We know these issues. We've been talking about these issues for years and years, and it still seems like we're missing the mark a little bit in terms of getting them on the ground. And we see that in a lot of urban communities. Some of these programs might work, but how about in rural communities where there's huge distance between patients? They may not be able to have the same resources we have here. That's another issue that I think about. And then one more that I'm thinking about as well is how do we bring, so translating into practice, and also how COVID-19 exacerbated so many of the issues that we know are there. And now we see so many seniors that are deconditioned because of social isolation and loneliness. How do we pick up all the pieces and start rebuilding? Can we make small changes? Or is it almost like we need a transformation? We need a whole change in our system. And how do we do that? As young researchers, how do we advocate for this? And how do we go and talk to the individuals who can make a difference?
No, it's great. It's a great series of questions here. And I think the first part is, I think there's always that research policy disconnect. And one of the challenges I often find is that when I go to various conferences or I read various papers, people, the whole way our research system is organized, it's almost like, okay, you've got this many words to publish in your journal article, and this is what you're being ranked upon. But I always ask the question, like, this is a great finding. So what's the policy implication for this? And we often don't encourage our researchers. I always want to say that at every conference and in every journal, we have and what's the policy consideration here? Because I think often we reward researchers for figuring out an answer, but not necessarily encouraging them to help show what that policy action can be. So one of the reasons why I love doing policy-based research is often actually looking at the great research that many of my colleagues do, but also helping to translate that into a compelling narrative that speaks to how these things can actually come there. Because often we don't have enough time spent from a policy angle focusing on how do we take these things and then translating them into actionable policy recommendations. So that's something that I've been having a lot of fun doing, but we need more people in that space. In terms of the idea about thinking about rural communities, absolutely, right? So, I mean, for this talk, I was focusing on what we're doing about age-friendly cities. What I did yesterday when I was working on this presentation was I took out the word community and I put city, because again, in Toronto, we're a city, if you will, but often actually the Public Health Agency of Canada helped to actually fund a lot of the original work with around the age-friendly communities kind of framework to really think about the needs of rural and remote communities and how there are unique needs. And actually there are lots of really good examples, again, back to the evidence, speaking about things that can be done, but differently in rural and remote communities to help people stay engaged. And to your question about, again, these small acts of change, or do we need a transformation? We absolutely need a transformation. I've been arguing for a national senior strategy, for almost a decade now. And I'm like, oh my God, why don't we have one, for example? And why aren't we doing this as well? We need to actually have a transformative strategy. We can't use incrementalism to create the change that we need. Otherwise, we're going to be discussing the same issues 10 years from now as we are today. And frankly, some of my slides haven't really changed from a decade ago as well. That disappoints me. So we do need a transformational change, but I think, as you said, what we can do from the COVID-19 pandemic, which is not over, is also appreciate about what we have learned and what vulnerabilities have become. That's why developing new national long-term care standards, thinking about ways that we can better address and recognize social isolation and loneliness and how we can address them, are ways in which we can at least identify the issues and, again, reinforce what are good, actionable policy recommendations that can create a sustainable system as well. So thank you. Those are 3 great questions. I will see if there's any other. I know I'm holding up between you and your lunch. We have a question at the back there.
nursing homes effective? Are they worth the money? And why does everyone hate them? And if they are worth it, how can we change the current sentiment?
Can you say the last part again?
If nursing homes are worth it, then how can we change the current sentiment about them?
Okay. No, it's great. I mean, I think this is the challenge. When we think about nursing homes or long-term care homes, they've gotten a bad rap, for example. We know that, first of all, people don't really think fondly of long-term care homes because nobody, as I said, wants to aspire to live in one. That doesn't mean that they're bad places or they're evil places. We have to remember there are tens of thousands of frontline workers who are delivering excellent care every day in these homes. The challenge why long-term care homes and nursing homes get a bad rap often is because, first of all, our governments are not funding care appropriately for long-term care in general and nursing homes in particular. So if you look at the OECD averages, for example, of what the typical country, rich country, spends on long-term care, that's home care to long-term care, Canada's an underspender compared to other countries. So countries like Denmark spend twice of what we spend of our GDP on providing long-term care, and 2/3 of their spending on long-term care go to care in people's homes rather than long-term care homes, whereas in Canada, we're the opposite, and we spend half as much, if you will. So the idea is that we have a grossly underfunded system, and when we have a grossly underfunded system, it also means that we're actually not staffing our care systems properly so that, again, people can receive and expect good, high-quality care. Because when we're not staffing homes properly, we know that, and we have poor conditions of work, we often say the conditions of work are the conditions of care as well. So I think the pandemic has raised that issue and it kind of forced the Ontario government, but others to start thinking about how do we get ourselves from a 2.75 hours a day average of spend when the government's own expert panel said 4 hours a day. It was actually our long-term care commissioners who came out and shamed this current government and saying, you need to actually get us up to 4 hours a day, which was an average number of hours established 20 years ago in a much different long-term care population. So we're incrementally working towards better staffing homes. And in countries where homes are actually well-funded, and we actually have a system where they're delivering the care that people need, there isn't a lot of angry sentiment. If you go to Denmark, people actually love their homes, but they also love living in their own homes. But they know that if they eventually need to live in a long-term care home, it's a positive change because it'll help them stay in their communities, but also get dignified care that they then need. So again, there's a way we can change our sentiment, but we have to respect these places of work and these places where some of our most vulnerable citizens live. So thank you for that question. I think we have one last question over here. Or you're just holding the microphone. There we go. That's a powerful role. So we have one last question over here.
Is your strategy also finding ways to kind of facilitate accreditation or training of healthcare professionals who are new immigrants to Canada to get them on board? Because I think one of our major problems is, PSW support, caregiver support.
Yeah, so one of the big challenges that we have right now is we actually have significant labor market shortages. We also have people who just don't have access to the right skills and training. You heard about my concerns about our medical education system right now that doesn't emphasize geriatric medicine and knowledge as well. We often find that a lot of our nursing colleagues, for example, don't get the level of training that they feel good about. And then it creates two challenges. One is it's hard to attract people into this area when they're not exposed to it. And number two, we see a high rate of turnover in these professions, such as those working in home care, those working in long-term care, often because people aren't given the skills. I know a lot of, when I was traveling the province looking at our PSW training programs, often personal support workers, for example, are trained on how to give a person a bath, but they're not trained on how to give a person a bath if they have dementia and responsive behaviors, for example. And I thought, well, wait a minute, 90% of people living in long-term care homes, for example, have a cognitive impairment, and the majority are living with dementia, and half are living with responsive behaviors. How would you not learn how to, bathe a person who might be living with cognitive impairments? And again, empowering family caregivers with these knowledge and skills as well, because we know that those caregivers who feel more confident about what they're doing, they're more confident about their knowledge, often feel more comfortable caring for their loved ones and being able to provide more care as well. So there is a huge knowledge gap that we haven't rectified within our system. But I think some of the goals right now are really thinking about how we can improve training overall. And certainly with some of the new national long-term care standards, the federal government has committed $3 billion over the coming few years to actually help provinces and territories improve the way that they're delivering long-term care through better kind of approaches around accreditation, quality improvement, but also support and training for staff as well. So I'm hoping that that will actually be a key investment that will start to accelerate some of the work that's needed. But you've actually hit it well on the head, is that we have to make sure that everybody working in our health and social care systems, our communities, are well versed in what some of these issues are, so that we can empower them to provide the care that they really want to provide more easily as well. So thank you.
Well, let's give a round of applause for Dr. Sinha. Thank you so much for that thoughtful and provoking talk. We now invite you to lunch. You'll see that there are white bags to the side. Please help yourself. I think there might be different dietary restrictions, so read the label on them. And we'll be starting back again at 1 o'clock. So thank you, everyone.
making art right now. So that's and training them. And then they're teaching nurses. And I find that those like athletes. If you sign on the dot, you got to go on top of and it was very much and then and I think that's still what allows for him. I think that recent they're interrupting and intersecting. And you see all these barriers that are preventing the people from having to work. And now you're doing I can't give it or I'll find a different solution. I'll find a different many of and then it's a very and then you get it's really, and for me to stay another, some people say, for me to stay gratified. Yeah. And connected. Yeah. Like, my mind keeps changing. I know.
Yes.
Things that we must, but you know what, those are the things that can help. They said 10 days. I haven't put one in a long time. They said I'll get an email. Yeah, yeah. 1 week.
Bring it in person.
Well, that's why I asked you for the gentleman with the dentures. So
Okay, you know what? Let's
but I wanted to make it good. I was up to 11 There was a gentleman who was with me. He was in the and he it's double involved.
No. They put some in there when they were in order to post and apparently they put it in there with
White tables by any chance? Well, good, because ours looked old right from the